I thought at the beginning we were talking about MPN, and I know for you it's very basic, it's undergraduate lecture. Therefore, Dr. Haytham, he called me and he said we'll talk a little bit about molecular. So I'm going in the first 15 to 20 minutes over the MPN very quickly. I know you know better than me about this because you're reading more than me. And then we'll move into some issues in CML monitoring and JAK2 mutations and next generation sequencing and all of these issues which is related to MPN and other topics. This is the first slide, the definition of MPN. It's a clonal hematopoietic disorder. There's a proliferation of myeloid lineages, either granulocytic, erythroid, megakaryocytic, relatively normal maturation. And these are the WHO classifications which you already know, and I'm sure you have prepared this: CML, neutrophilic leukemia, the polycythemia, ET, essential thrombocythemia, myelofibrosis, and some other classified. And you know already that there are an overlap between the three categories of AML, the MBD, and the MDS. And now we know the hypoplastic MDS and the MDS slash MPN. All this, I'm sure you know all of it. Now, how does it progress? How things can go? Again, it's very well known over the last maybe 20 years that patients with polycythemia can go to AML, patients with CML can transform into AML. Probably these figures are before the era of the TKI. We'll talk about the TKIs later on. Patients with myelofibrosis can go to AML, or patients with polycythemia can have myelofibrosis. So it is a topic that it's interrelated to each other, and you have to be aware of all the concepts. Now, median age, we know this is old age, although we have seen cases of MDS probably more, and even MDS, CML in pediatric patients, but CML also in pediatric patients. But this is the usual median age is 45 to 55 years. This is a textbook material. I'm sure you have read about it. The incidence increases with age. Yes, it's about 30% of patients are above the age of 60 years. Now we are seeing also younger ages in the 40s are having more MPN. The incidence is about 1 to 1.5 per 100,000. Again, this is a textbook material. It might be different from one country to another and from race to another. The presentations for the clinicians and the people in the clinical side, the insidious onset, the anorexia, the weight loss, symptoms of anemia, splenomegaly, all of this are very well known. Sometimes patients present just to the blood donor area for donation of blood, and then they discover that they have CML or MPN. Now, this is a typical picture of CML, and this is a typical picture of the 922. We'll go into the next presentation into more details of cytogenetics and molecular. Now, this is the fish, and I'm sure you know the concept of fish, and already you have, you know, the technique of fluorescent in situ hybridization. And this is a simple figure which shows some normal cells, which has two dots of the blue color and the red, which is the 9, because we have 2 9 chromosomes, and 2 dots of the other color of the 22, because we have 2 chromosomes, and you can have the fusion between the 9 and 22, and you can see the light yellow fluorescent coming out of fusion of these two, which will ultimately form the BCR-ABL, which is the new fusion gene, which will lead ultimately into the tyrosine kinase and will lead into the proliferation of the CML or the granulocytes into the chronic myeloid leukemia. And since 1960, we started knowing this. 1960 was the Philadelphia chromosome. We didn't know at that time, I was just born, that this is 922. Then in the 70s, they discovered it was a translocation between 9 and 22. Then in the 80s, they discovered that this translocation leads into a fusion between the BCR, which is on the chromosome number 22, and the Q arm, and the 9, which is in the ABL the ABL gene, which is in the chromosome number 9. Fusion of these two genes will form a new fusion gene called the BCR-ABL. So we started digging into these cases. They used to tell us that 95% of the CML cases, they have Philadelphia chromosome, while 5 cases, they might show negative Philadelphia, but they show BCR-ABL because the technique and the sensitivity of karyotyping at that time was very low. Now you have a BCR-ABL, then you have diagnosis of CML. Why this fusion gene? So what is wrong about it? We know the fusion gene leads to the tyrosine kinase, and then people started in the 2000s discovering the TKI. The first TKI was the imatinib, which was a breakthrough. We have patients since that time. They are on TKI and they're surviving, and they are monitored by molecular and FISH probably, and we'll show you some of these figures in the next half an hour. So that was the natural history of MBN and CML, and then people said, okay, if CML has BCR-ABL, then other MBN must have something else, and the JAK2 mutation came into the scene, and so far we have analyzed more than 1,800 patients for JAK2 mutations. The results will be shown later on, and maybe will be published by other colleagues, residents from your group. And this is basically what I have talked about. Then how we are going to detect, and this is the natural history again of the molecular techniques. At the beginning, when we started molecular 94, 95, the only technique was available is the Southern blotting. And if you remember, the Southern blotting was a technique which depends on probes, not on primers. And I would like you later on to read about the difference between a probe and primer. We use probes, and these probes has to be hybridized into the BCR-ABL. It has to use a radioactive material, which was the B53 at that time. And as you know, B53 and radioactive material in general is now abandoned from laboratories because of the risk of cancer, especially in breast cancer. And the time, it's very time consuming. It takes 2 to 3 weeks, and then you have to use the radiology department to expose these x-rays, and ultimately you might end up with an overexposed or underexposed x-rays. Interpretation, it was quite difficult because you have bands, well, I'll show you later, that it could be positive for or rearranged in normal subjects, which is not related to the BCR-ABL. So all these difficulties. Then in the 90s, later in the 90s, maybe 98 and close to 2000, BCR became the standard technique. And as you know, there are a BCR, primary chain reaction. You need to know the principles of it and read about it. It might come in the exam. Then the RT-BCR came, reverse transcriptase. And what is the difference between BCR and RT-BCR? We were not able to do BCR-ABL on PCR, conventional PCR, because conventional PCR used DNA. And the BCR-ABL, you cannot, it's a huge sequence that you cannot run it on DNA. You need an RNA. And you know RNA is a small copy of the genes of the DNA on the nucleus. So you need to extract RNA. Now, until that time, techniques were not available in extracting RNA, and RNA get degraded very quickly within 4 hours, maybe maximum 1 day it will degrade. So you need a fresh sample to get the RNA. So we were able to extract the RNA, but it was not able to do PCR, but the RT-BCR was discovered. Reverse transcriptase, which is using the reverse transcriptase enzyme in converting the RNA into DNA, because you cannot run RNA on the BCR. So you get the BCR, you add the RT, reverse transcriptase, and then you run on a template of DNA, and we were able to do, at that time, the BCR for BCR-ABL. And you can see we use a ladder, which is base pairs, and we run also controls, and you can see different bands, which is either positive or negative. Okay. Now, sensitivity matters also at that time. We know the PCR is very sensitive, but the sensitivity we were using is 1 over 10,000, which is 10 to minus 4. So we can detect one abnormal copy of BCR-ABL in about 10,000 normal copies of the normal gene. You can use the normal gene as the BCR, you can use the ABL, you can use the G6PD, you can use any other control. And when I come into the monitoring, this is very important because variations are many actually. And whenever you do test of BCR-ABL in X hospital and you try to repeat it in Y hospital, you will never get the same figures until today. Okay, so standardization of this test is going to be a real challenge. So to make it more sensitive, because at that time we were using this just to diagnose, and we have the karyotype of Philadelphia. Why before the TKI we were using the BCR-ABL, using the PCR? Because of transplant. Those patients, they get CML patients, you know, the natural history of them, they might end up and die within 2 to 4 years, transformed to AML, or die from the complications of it. So the only treatment before 2000 was the bone marrow transplant, the allogenic. So now when patients get transplanted, then how would you make sure that they are actually lost the Philadelphia or the BCR-ABL? Because cytogenetics is very flow sensitivity. FISH was not available at that time. Even FISH is less sensitive than PCR. We use the BCR-ABL for positive or negative. Then patients, even after bone marrow transplantation, they still show positivity for the BCR-ABL. What does it mean? Now, if the patients continue consecutively at least 2 to 3 times having positive BCR-ABL after bone marrow transplant, then the patient is at a very high risk of relapse. And you, your colleagues, clinicians, will intervene with those patients by using DLI at that time. Okay? Maybe DLI is still available until now. So for this, we needed a more sensitive technique of PCR, which is 1 over 10,000 is not really enough sensitive. So we used what we call nested RT-PCR. And you have to read about this terminology, because when you say PCR, there are many different kinds of PCR, including what we call multiplex PCR. Now, the nested RT-PCR, it's an RT-PCR, but it is nested because we are amplifying the amplified. So we amplify first cycle of PCR, and then we re-amplify that thing which has been re-amplified. And you can imagine the risk of being oversensitive, because we are going into now 1 in a million, that you might amplify some normal genes. And it happens actually. And some even normal subjects, they might have normal genes. If you go into nested RT-PCR, you might amplify their normal genes. And then it will be question mark, why should a normal subject have a BCR-ABL positivity? So these are the old techniques, but it was only qualitative. It's not quantitative. So after TKI, we needed more quantitative technique, so we can measure actually the amount of the disease or the BCR-ABL. So the real, what they call the RT-PCR, now it's not RT reverse transcriptase, it's a real-time PCR. And then because of confusion between the two, they call it QRT-PCR, quantitative real-time PCR. And it is real-time because, as you can see, you are measuring cycle by cycle. So we are not waiting until the last cycle, which might be 30 or 40 cycles. You are measuring cycle by cycle. So now it's a real time rather than being at the latest. And then you can quantitate. You have to have a normal control. We usually use the ABL or the BCR as a normal control, so you can later on make a ratio of the abnormal and normal, and you come up with a figure which is called the BCR-ABL ratio. Okay, so this ratio will be used later on for monitoring of patients. And you can see it differs from control to control. It differs from reagents to reagents. It differs from different machines. So you have the real-time machine, you have the Roche machine, you have the Tachman machine, you have different platforms. You have people using only 29 platforms. People are using more like 96. So all these variations also affects the results of the ratios of the BCR-ABL. Okay. So these are also the phases of CML. I'm sure you know about the CML median 4 to 6 years, stabilization, the median duration of accelerated phase, plastic phase, and now we are talking about different TKI. When I started my residency or so, we started with busulfan. Arsenic we did not come with at that time, and the radiation therapy. We saw the area of busulfan, and ultimately, definitely, all of you have reached the era of hydroxyurea. Then the transplant was at King Faisal when we were residents in the 80s. We had the chance to see the CML with severe acute GVHD. And fortunately, alhamdulillah, the people came with the imatinib, and they are not having more sufferers of the GVHD. Interferon also came for multiple myeloma and CML at that time. Still, maybe some people, I know people, they are using in Saudi Arabia hydroxyurea as the first and last line of therapy for CML until today. Didn't hear yet about the imatinib. So now imatinib is not the only one. There are many other TKIs are available right now. Now our part in the lab, as a lab being course, is how we can help in diagnosis, accurate diagnosis and monitoring of these cases ultimately. Okay, these are the issues related to BMT, and this is the imatinib. Okay, drug associated. It's all in the textbooks. Polycythemia, and I don't want to. JAK2 mutation. Okay, now we do this mutation, our Sanger sequencing, and we have results similar and figures to all other countries. Samples are coming from all over the country. Actually, we did in the last couple of years, we reviewed, as I mentioned, 1,800 samples. We are in the process of seeing what are the different positivities. They are very common in non-CML MBN. They can be seen in myelofibrosis. They can be seen in ET. They can be seen in other non-CML MBN. There are different mutations, but the V617F probably is the most common one. But we will come into the different mutations that we can find in our population. Clinicals, some of the clinical features, I'm sure you know all of this. Diagnostic criterias. And this is the schematic graph that shows when you go for bone marrow biopsy, when you go for some others. And actually, especially for CML, nowadays what is going on, and I'm sure you are aware of this, that when patient comes with a high count for possibility of MP, and the first thing you will do after the peripheral blood, you'll do the bone marrow. And bone marrow is done mainly to see the degree of fibrosis, the cellularity, and if there is any evidence of myelofibrosis. But also you need this for the karyotype. And it will be very important to do karyotype on bone marrow at the time of diagnosis, and not only to do molecular or FISH. Because again, BCR-ABL, if it is positive by FISH or by molecular, that is enough for the diagnosis of CML. However, you are going to miss, if you don't do karyotype, some additional abnormalities that are shown by the karyotype. Additional abnormalities, which means that this patient is not probably in chronic phase, although morphologically he looks in chronic phase. He might be already going into transformation or into at least acceleration phase. So you need to know this information up front. Okay? Now, when you are going to repeat this karyotype, and if you are going to repeat the karyotype after 6 months, or 3 months, then you have to have a baseline, because at the time of diagnosis, you are not sure what was the abnormality. Is it Philadelphia alone or Philadelphia with additional things? So it might be overkilling at the time of diagnosis. We are doing bone marrow for karyotype, Philadelphia chromosome and additional chromosomes. We are doing FISH. And we are doing also molecular for the ratio. So the diagnosis is enough for one of them, but I need the molecular at the time of diagnosis because this is a baseline. If for some reason the molecular was negative technically, or because of different primer set, whatever the reason is, then you wouldn't know when you are monitoring that this patient was actually what was the original figure. You cannot use the original molecular figure of the ratio as your basic standard for log reduction. This might be a mistake some people might be doing. If you have a ratio of X patient and then you try to monitor this patient by molecular on not international scale, I'm talking about the log reduction. If you go for log reduction and then you have to calculate it from this baseline, you will be totally wrong. Because those patients, they come up with different figures at the time of diagnosis. The right thing to do is to bring 30 figures of 30 patients new, non-treated, with definitely there will be different levels, and you make a ratio, an average of the ratio, and use that average as your baseline to measure the log reduction of each single patient. So monitoring CML depends on either, I'm not talking about treatment, and can you move into the next presentation, please? Hello, you hear me? So this is the way if you want to monitor chronic myeloid leukemia on TKI, whether it's imatinib or some others. Either use the international scale or use the log reduction. So when you reach a level of 3 log reduction from the baseline that you have, then the patient is in major molecular response. And this is important because some people, they think it's cured or treated or not detected. Yes, you reach a major, this is the definition, a major molecular response. But it's not complete response, it's not detected at all. Still the disease is there, but you reach a target of a major molecular response. And this is either by international scale, which is 0.1, okay, or 3 log reduction. Theoretically, they should equivalent. They look equivalent, but it's not. In real practice, you cannot jump from one to another. Either use the international scale or use a log reduction. And different techniques will force you either to use this or that. If you use the TACMAN and conventional PCR, quantitative, which everybody is doing, then you end up with a ratio and you calculate the log reduction. You will not have the international scale. If you use some other techniques like the CEPHID or the expert gene, okay, this is a machine available in our labs, whether you know it or not, over the last 10 years. But it's mainly used by virology, for molecular virology detection of viruses, and it's not used by the hematology people for one reason. And also the reagents, the commercial reagents for BCR-ABL and for others came up at a certain period of time from Roche and then discontinued because commercially they are not cost effective for the companies. For virology, yes, you have loads. So you can produce kits and sell them. But for hematology, BMR-RARA and BCR-ABL, the number of cases is not really that much to generate reagents. Therefore, we are using in our lab our own mixtures. We used Ipsogen for some time, and Ipsogen is a good reagent. They are Assuragene, and they are different now coming kits. But you don't want a discontinuation and change from one kit to another, so we are using our own in-house mixture for the BCR-ABL, and I'll come to the global international scale, which everybody is talking about, okay? So, but if you use this machine as an example, it is available in at least 3 or 4 hospitals I know. You end up by having international scale, IS. And then you have to monitor your patients on the international scale until they reach 0.1. Then they are in major molecular response, okay? But you cannot compare this with results from King Faisal or another lab which has log reduction. So ultimately, patient has to stuck with you in your hospital with the same methodology so you can monitor him. But if he goes to another hospital, then there will be variations. And I will remind you, I know you don't remember probably this because you are young, I remind you of the warfarin and prothrombin time. It's the same problem. If you get prothrombin time at King Khalid Hospital, you go to another hospital, it might be different. And then the monitoring of warfarin therapy will be different. In one hospital, it might be overdose, another hospital it might be normal, etc. Same thing is happening right now. So when during our residencies, they came up with the international normalized ratio, INR. And now wherever you go, the INR should be the same. And the main reason was, if you remember, any technical people remember why? Huh? The reagent. What is wrong with the reagent? Tissue thromboplastin. What is wrong with tissue thromboplastin? Different, okay. Different resources, you mean animals, different brains, different lungs, okay? And? Okay, so the purification of this tissue thromboplastin is different from one company to another. So you find the ones which is not very well purified, very cheap, and this is good for tenders of Ministry of Health and others, which they have millions. They want something cheaper. But now the purification will be low. If you have a small private hospital, you might go into the expensive one. However, if you have the what is written on the tissue thromboplastin on the kit? ISI, International Sensitivity Index. And if you have international sensitivity of 1, this is excellent. If you have 1.2, 1.3 until probably some of them 1.8, then the sensitivity becomes lower. But at the end, if you are multiplying this with the prothrombin time ratio normal over abnormal, then you come up with an INR which should be within a reasonable standardization is acceptable. And your patients between 2 to 3 probably they will be managed with warfarin. But same thing applies now with this PCR-able. Variations are many in the reagents and the mixture. I'm using my own mixture. Some other people using Epsigen. Those guys are using Cepheid. And Cepheid has its own cartridge. You don't need to extract RNA or anything. You just put the cartridge and then you get the results. In our labs, we do RNA extraction. So this is a step outside. In all techniques which use PCR, there is a step of RNA extraction. And that's, again, a variation. Then there is a step of variation of the controls they are using, the variation of the amount of the level of detection. So there are many variations which will not allow you to compare results from different hospitals. Therefore, please monitor your patients according to the results coming from your lab. And they are all right, they are all standardized, they are all correct. But we have patients moving outside the country. We have physicians and colleagues who wants to participate in global studies of TKI. Then if this is the results from different countries, Italy, Saudi Arabia, results will be different and it will not be acceptable. So we want to come up with another INR, similar thing, which we call the global international scale. And so everybody's aware of this machine. So you will hear about this. It's all in Ministry of Health everywhere. And if you want to do your PCR-able, use this machine because it will be simple and easy. And I'm sure it will be in your microbiology lab. You just buy the kits and go and do monitoring of your patients. But it gives you international scale, but this is not the global. This is the mistake that many people, they claim, we have international scale. I know you have international scale, but this is not the global international scale. This is not the INR of coagulation, okay? So simple, easy, and you can have even the Infinity, which is a huge machine the microbiology are using for standardization. Okay? Now, this machine, anybody remember this machine? What is this machine? Okay, so DNA extraction or extraction used to be done manually. Many labs, they are still using it manually. Time consuming, and this can show you also the variations of the test. But people came up with automated machines. Now, this is the latest one in our lab, which is 96. So we can put 96 samples because we do an average of 100 per day. So in the morning, we will run the two machines, one for RNA, one for DNA, and that will save a lot of time within the same day. Hopefully that within a couple of years, this machine, DNA RNA extraction, will be attached to the TaqMan itself, to the PCR. So you will be moving the samples automatically from the DNA RNA extraction machine into the PCR machine, the real time. Okay? And anybody remembers this machine? This is the next generation. So we use PCR for these translocations, BMIR-RARA, quantification, PCR-ABL, but we have many, several hundreds of mutations are coming into hematology. JAK2 mutation is just one of them, okay? You have also the FLT3 mutation, and you have about at least 250 mutations in acute myeloid leukemia. Maybe 16 of them are in common practice. Already you have anti-FLT3 drugs are available, so you need to do anti-FLT3 mutation. So the technique is not PCR. So we have talked about DNA extraction, we have talked about the conventional PCR, RT-PCR, quantitative PCR. Now people are into sequencing over the last 10 years. So you need a sequencer in your lab to do all these mutations. You can measure everything, but it's going to be very difficult. But if you have targeted mutations in hematology, like 20, 22 mutations, you can target them by sequencing. Again, it's not enough, because today we do FLT3, tomorrow we do MBN, the next day we do this. So it takes you 12 days, 20 days to do one by one. And then by the time the information goes to the oncologist, it's already either too late, or he could have acted early. Now, at least at the beginning, we are trying to get the FLT3 and MPN, which is probably more related, within the first 72 hours or 4 days. And then the rest will come. However, the next generation sequencing, we believe, and other people believe, it might be just another era and disappear, but this is what everybody is moving to, is the next generation sequencing, where you can do a parallel mutation study. And what we designed right now, we have a chip like this, which can take thousands. You can customize. And the research center are coming up with a chip which is 2,400 mutations. And I don't know if you get this information, who's going to analyze it for you. You need a bioinformatics expert to analyze this. And how we are going to apply it into your clinical setup, I don't know. But we decided to go target. We are doing like 20, 25 mutations right now. Why not to increase another 25? Because MDS also came up with some new mutations. I'm supposed to, how long do I have? 15? 15 minutes? Okay. So we decided to go and do 2 chips, one for hematology, one for cancer, solid tumors, for lung and breast and all of this. And we are using 50 genes only, which is more than actually what we need. If you look into the genes we need, maybe they are not more than 26, but we put all the related hematology genes, because in MBN, what are the ones you know? You know BCR-ABL, you know JAK2, BDFR, okay, that's for, we're using the bladed-derived growth, okay, and CMML and all, okay. Okay, and KIT is also, we are doing an ML, okay? MBL, okay, MBL. And finally, there is a new one. MBL, okay, MBL, and finally there is a new one. Calreticulin, okay? So at least these 6, 7, 8 MBN genes we have addressed into this chip. So we'll see how things goes into this, okay? In addition to the ML genes. And see, this figure just not to show off how much we do, but it shows you how much is the impact on you as a laboratory guys coming into the scene, that this became demand. This became a demand. In the 2011, you see the number of cases, more than 4,000. And I'll show you now, last year, we were doing like 16, 17,000 samples. And each sample will have more mutations. And so, yeah, you cannot escape this. We can escape it because you are old enough, we are going for retirement, but you cannot escape it because your colleagues on clinical side, they will keep asking about these mutations and these things. So you have to set it up, you have to learn it first, you have to get more experience, and it's not difficult. When you finish your board, you can go for 1 or 2 years, you can spend more into, there are masters, there are programs, there are American Board of Molecular Pathology, and you cannot escape this because this is the future that all patients will be treated. And when you have a relative who has a leukemia or MBN, you start asking about these things. You want to monitor, you want to send to my clinic, you want to send to, but you are not making the effort for other patients and trying to set up these things in your laboratories. And it is much cheaper now, more automated, much cheaper and easier than cytogenetics conventional, if you want to go through this, okay? This is the short list that we have, but it's going to be more and more, okay? And one of them was the SNP array. And SNP array was used for medical genetics, actually, cases, which again, a big demand because of the non-availability of SNP array at that time. We spent 4 million reals only testing abroad in Columbia University for our patients. Why shouldn't be able to set up a SNP array and run it? Okay? These are the different mutations that we have right now. It's not enough, but at least these are the basic ones that we have right now. This includes the resistant mutation. Now, we treat your patients or your colleagues in clinical and oncology, treat patients with TKI, and then at a certain stage, they have some non-responders. And they are wondering whether it is because of the patient medication compliance or because of the mutations, and they want to do mutations. And I say, okay, we send it to my clinic. I mean, basic mutation we should be able to do if we have a sequencer, okay? And we did sequencing. I reviewed the last 2 years, 2013 to 2012, and we had like 100 patients positive for different mutations. So there are about 5, 6, 7 different mutations, but there are some of them which are more common and you should learn about them. So if you get a question in the exam, you cannot say, I don't know, these are mutations, these are molecular, but at least the basic common different ABL kinase mutations, you should be able to know that is causing resistance. Then the question comes from your clinical side. When you have a mutation, does it mean that the patient is not responding and you should change into a different TKI? Or could the patient have non-response without even showing a mutation? Should we do the mutations upfront at the time of primary, whether this patient has a primary? Is TKI gets resistant to a mutations which is already existing, or did TKI enhance a mutation which was present but in a very low level, and then when you use TKI, some patients they have, all these questions are important. But there is an article in Blood which is about a year ago, which address all these issues, and you should read it. You just go in Blood, Bakarani and other colleagues, you will find the answer to these questions and what we should do right now. you are doing, I know the clinical people, monitoring CML with fish. Is fish part of monitoring CML? Give me an article which says that you can monitor CML with fish. In our all laboratory, in our all hospitals, we do by fish. Now, the only reason, because you don't want to do bone marrow at 6 months. And you assume if you do fish, it's much quicker for the patient, it's only peripheral blood, and then you do fish until the percentage becomes 0, because a fish can give you percentage, although we are talking about 100 cells. We are not talking about PCR in millions, okay? So when it goes negative, then that means patient is Philadelphia negative, which is not always right because nobody studied that. And if it is correct, when did this patient become Philadelphia negative? 1 month ago, 2 months ago? You never know, okay? And the monitoring of those patients depends on cytogenetic, or their outcome depends on cytogenetic remission. Now we are saying fish remission, but not cytogenetic, not actual cytogenetic remission. So you will not be able, even if you move into international global studies, they will not accept it from you. So I can see our colleagues are going back into 6 months bone marrow. And you should do 6 months bone marrow, and you do karyotype, so there will be no real need for fish. And then you continue the molecular until you reach the major molecular response. Now, we do also chimerism, and I'm sure you know about this. This is CML, Philadelphia, and we talked all about this. And this is the nested RT-PCR real time, and this. You can see the demand on the PCR able. And again, you have to remember that PCR able can be positive in CML, can be positive in ALL. But what is the difference? Huh? Okay, so the protein is different. P210, P190, okay? 230, that's another rare thing. But now if you have a patient who is blastic, has 20%, 30% blast, and he reported as ALL, Philadelphia positive, could this patient be a CML transforming into ALL? Could be. Now, how would you know that this patient is P190 or P210? Okay, so we used to have 2 tests. When you send a patient for PCR able, we have 2 tests. One set of primer for 190, one set of primer for 210. And we have to run both. And this is time consuming, and we know the number of 190 is much smaller than the 210. So we decided to have a primer which covers both 190 and 210 PCR able. So if we tell you that this patient is PCR able positive, the next step, which we ultimately do it for you actually, we do the subtyping. Then we go and find out whether it's 210 or 190. And we'll do it only once at the time of diagnosis. So if we know it's 210, khalas, that will be the end of it, and every time the patient will be done. But that saves time and efforts for not doing 2 tests. But you have to remember this, so you don't take it for granted that this patient is 210, is not 190, or the opposite, okay? Until you see the subtyping. Okay? This is an example of a patient. This patient could have gone for, at this time it was 2003, could have gone for transplant, okay? But they decided to go, he was in chronic phase, he was on hydroxyurea, Philadelphia was 100%, and this was the molecular 15 over 100, so it's very high, and then managed to, 2014, to go into 15 over 1,000, and then I mentioned at that time our cut level was 1 over 10,000. Again, this is the problem you have to, some physicians, they bring me a result, say, well, at this X hospital, it was not detected. In your lab, it is detected. Or in your lab, it's not detected, and in my clinic, it's detected. You have to know the threshold, the sensitivity they are using. Yes, I am using 1 over 10,000. This was back in the 2004. If somebody is using 1 over 100,000, he will be positive. Okay? But in my lab, it's not detectable because this is the threshold that I am using. And because it was not enough, we decided to go and do nested, which is, if it is negative below 10 to over 10,000, 10 to minus 4, we go to nested, which is 10 to minus 6. And still the nested is positive, or the patient is doing fine, okay? Until a stage when the nested becomes negative, which means this patient has no single copy of abnormal in 1 million normal copies, okay? This is the level of detection. Now, when we moved into the Epsigen, yes, Epsigen was 10 over 10 to minus 6, so we did not need to do nested, okay? And it moves like this. Then we started the log reduction. You can see the ratio, and you can see the log reduction. 2013 patient log reduction was 3.3, which was doing fine, okay? And then after that, it becomes the level very low to the level is not detected in our laboratory, at least, not applicable to do the log reduction. So these variations, please make sure that variations of this until hopefully we get the international scale standardization. Do you know how we can do the international scale for BCR-ABL, the global standardization? What is the method and the way to do it? And why wouldn't have it in the Middle East? Why wouldn't have it even few labs in Europe and in America, they have the, why is that? Because there are a lot of talks, and I want you to be clear about this. I mentioned international scale from CEVID. That's a standard international scale. It's not the global. CEVID, they are using reagents they call V1, version 1. And it is not acceptable for global international scale. So they told us about a year ago, or maybe less, that they will come with version 2, V2, which will be WHO approved for global studies. So everybody can move to CEVID and do the version 2, the CEVID reagents, the expert gene, and it will be equivalent in all hospitals because its WHO standards are in the cartridge itself. However, 3 or 4 months ago, they said, sorry, we couldn't do it. There is no approval from WHO. It might take longer time to do this. So if anybody tell you that I'm doing CEVID international scale, tell him I know the story. Yes, you are doing international scale, but this is not the global international scale until we get the V2 available. Now, other methods, definitely they don't have this international scale unless what? Anybody can answer this? Huh? Unless they have, why some labs they have international scale in America and Europe and Australia? How they do it? How they get their international scale? They do it, there is a reference lab in Adelaide. A lady called Sandra, she might examine you if you go for a Farsi BA one day. And they have a reference international lab, was supported by the drug companies, Novartis and others. So they are doing a great job in standardizing this. So if you want to standardize your lab, all what you need to do, get 30 samples, run them in your machine. These samples needs not to be new, don't include new cases, and don't include negative cases. Therefore, we are trying to target patients who are in treatment in the last 12 months. So they have different levels. They are not very high. They are not detected. And they need from you 30 samples at the beginning, 10 from higher levels, 10 from lower, and 10 in between. And once you send them this, and you have to make sure that it reach over there in a proper time, the RNA is integrated, and this is all difficulties. There is only one global carrier who is not available in the Middle East, who can carry this. FedEx, DHL, all of this, they will get it lousy. And it happened with us and with our colleagues, okay? So what you need to do, 30 samples, send it to Adelaide, and Adelaide will give you a conversion factor. Whatever test you are doing doesn't matter, whether it's CEVID, whether real time, whether it's Tachman, whether you just multiply your results by the conversion factor. And then you will have the international scale, the global, and you will be accepted in global studies. If you don't have this, your results internationally will not be accepted. It will be locally okay for monitoring your patients, but you cannot compare it with people globally. Now, once you get the conversion factor, you have to send another 30 samples. And imagine CML is not diabetes. You get 30 samples in few days. You have to have time, 3-4 months to collect 30 samples, okay? And the second 30 samples is used for validating your conversion factor. So you're talking about 6 samples, okay? Hoping that it arrived in the right time, in the right place, with good integrity. So that's why most of us, none of us has a conversion factor. We had conversion factor the first 30 samples, that was about a year and a half ago. And then when we sent the second validation 30 samples, it lied up in the customs for a week or so and everything went wrong. So now we have, and every time you change your machine, or you change your reagents, or you change your procedure, you have to do it again. You cannot use the conversion factor of 7 into Tachman or reagents from Abdullah Fuad to reagents from Roche. If you change anything, you have to start from scratch. And this is what's happening with the prothrombin time, by the way, so you didn't know about it, because every time you have a new lot, you have to change the internal. You cannot just continue using the ISI of the previous lot. Okay? So same thing. So it's cumbersome, and I know why people are moving from the lab to the clinical. You buy the drugs, give it to patient, and he will be in remission, inshallah. Okay? And leave the rest to the... This is the JAK2, okay? And these are the mutations of the JAK2. And when you say JAK2, you are talking about different exons, and whether you are using 12 and 14 and 13, whether you are screening all of them, all these issues will be addressed, okay? Then, and these are the different ML. I don't want to talk about it, and these are just examples. Okay. Now, in next generation, as I mentioned, this will be the thing that you should be reading about. It might come into your exam, especially if you are going for basic pathology exam of the Royal College of Pathologists. They might give you an essay about next generation sequencing, because this is the era now. Everybody is talking about it, okay? And it can be the whole genome, it can be the exome, and as mentioned, we are going for targeting certain genes just to save time. It takes to run the machine, to run this next generation sequencing, about 3 days. Adding 1 more day for RNA extraction or DNA extraction, adding 1 more day for... So within a week, you will be able to handle all the mutations of ML or MBN to the clinician. Okay? You tell him that he is BCR-ABL negative, he is JAK2 negative, he is MABL negative, but he is kallikrein positive. Okay? So instead of fragmenting it day by day, remember, the more you put genes into these chips, the less is your sensitivity. It becomes even less sensitive than the conventional sequencer. So when people talk about 2,400 genes, I will give you all of this, sensitivity will be much, much more lower. And the number of samples you can run. Now, with the chip that we have right now for experimental, we have 409 genes. You can run only 4 samples. That means every week you run only 4 samples, which is really a drawback. There are larger chips which can take 8 or 16. But again, if you limit the number of genes that you are interested in, the end result interpretation becomes much easier, okay? And the number of samples you can run as per day or per week will be higher, as well as your sensitivity will go much higher. This is the chip we have right now with 409 genes. We selected the MDS, ML, MBN, all of this into one chip, and the cancer, lung, and others, EGFR, and BRCA1 and BRCA2 into another chip, and hopefully things will work nicely. These are the different ML genes. I am not, okay, I think I'm done, unless you have any more questions. Okay.
Thank you, Dr. Salim Khalil. Any question? No.
My question is regarding the detection of the PCR-APL by molecular.
تفضل.
You said that you are detecting the whole breakpoints all together. I want to understand how. So we know there are different breakpoints. We have E1, we have E13, we have E14 and E19 together with A2, the breakpoints, the 190, 210 and 230. So how we are detecting that? How you are detecting that with one test only?
You must be from the lab, huh? Technical person?
No.
Okay.
Actually, a clinician.
You can design your primers the way you like. Before we design primers only for the 190 sequence. Now you can design it for 210, but you can design it for the whole thing together. But again, although we have designed these primers for both the 210 and 190, it doesn't cover the 230, the 320, which is usually we send abroad. So yes, from the technical point of view, yes, you can have primers which covers whatever sequence you want. And that will be, when it is 190 positive, it will be positive. When it is 210, it will be positive, but you didn't know which one is the positive one.
Because, for example, I'm not from National Guard Jeddah, they are doing only B210.
They are doing?
210.
Yes.
Only. So when we do 190, we need to send abroad. I want to understand why they cannot do it.
If they can do 210, they can do 190. There is no difficulty about it, but probably they don't want to just to add one more test, which is not commonly practiced, requested. This is their choice, but if they can do 210, they can do 190. There is no difficulty, just choosing the primer. But we decided, or one of our senior colleagues when he was here, decided to get primers for both of them at the same time, so you don't have to. And then when it is positive, because most of these cases that you see, we do 2,000 BCR able per year. And this all just monitoring and follow up negative, and so we do only at the time of diagnosis just to make sure. And if it is CML, then it's unlikely to be 190. Yeah, it's usually 210. But we do the subtyping just to make sure that the LL is 190, not 210.
Sorry, just the last question, just to clarify it. So if you get PCR-APL positive and you want to know it's 210 or 190, what you do, you look at the break points in the PCR, the E1 or the E13, 14.
True. We have a separate primers for each of them, and we'll do them separately.
So you have the whole primer, then the separate one.
Exactly. So we do screening the whole thing, and if it is positive for the first time, then we do both to make sure which one, and we report the results after 1 week or two as 190 or 210. But if it is CML, our colleagues, they know it's 210 and they continue management. I don't think an MBA in 1 or 2 weeks will make that much difference. Yeah.
Thank you, Dr. Salim. Any question?
And if you don't have questions, and I want to go, we went into the area of molecular. 5 minutes or 2 minutes actually. I want you to be aware of the area of cytogenetics. You know the karyotype, okay? The conventional. And I'm sure most of you passed through the cytogenetic lab and they have seen how the harvesting and the metaphase finding and why we need bone marrow, not peripheral blood. Many physicians until now, they send leukemic blood for AML and CML, and we reject it and we say we need bone marrow for this, and that's why in CML you need bone marrow a day after 6 months for CML. Now, any questions in this area, why and how, or why don't we move into sky karyotyping? What is a sky karyotyping? And what do you think, if you know the principles of fish, how can fish replace the conventional karyotyping? Can it replace? And the message from a person who's in the lab for the last 29 years, I want to tell you that none of these next generation or sequencing or fish will replace the others. People at the technical level, our lab is the most important. If you don't have molecular next generation, you are nothing. No. Each of these are very important tools. Morphology will continue until ever. When I joined the program, maybe Dr. Mashadani remembers, Dr. George Roberts told me there will be a machine called flow cytometry. That was in 85. And the machine came actually in 85 to King Faisal, and he just put the sample, it will tell you MLL, there will be no need for you as hematopathologist, so change your specialty. And you can see now, you are residents and you will be consultants, and your residents will be consultants, and still you need morphology. Okay? So morphology will continue. Flow cytometry is a very, very powerful machine, very powerful technique. You will never get rid of this, and you will need it forever, flow cytometry. And you cannot work without flow cytometry. If you don't have flow cytometry in your lab, it has to be established. But again, the same thing. When fish came, they said, "Khalas, cytogenetics is out, Caritab." Fish has its own limitations, like any other technique. And what are the limitations? Yeah, actually, you are not fishing. You are targeting. You are hunting. You are going to a specific probe, and if it is BCR-ABL, doesn't mean the rest are negative. Okay? So, again, fish is very important. Fish is very nice because it can give you results the same day, especially when you have a case of Burkitt's lymphoma, leukemia, and you just want to see if c-Myc is positive or negative. Same day, next day, maximum, you can have a result of c-Myc rather than waiting for the conventional karyotype, which should not take all this time again. Our turnaround time for karyotype is 28 days. I don't know what you do with the result of 1517 translocation of M3 after 28 days. We do fish, we do molecular certainly quickly, but we have to improve also the karyotype. And this is what we call the applied spectral imaging. Anybody heard about this? The SI? You have an advantage over us, the old-timers, that you know computer very well. And when we were residents, Dr. Mashadani will send us to the library to find a book which is published in 1965. Now you go to the internet, you go to Google and just type SI and everything will come to you. Why? In your bedroom. Okay? You don't have to go to the library. So try to update yourself what is going on in the era. Not only reading the conventional MBN, CML, and you have to get, because you will be moving soon. Not later. Soon you will be moving to Ministry of Health, to other hospitals where you are supposed to establish things and build things, and So please try to attending meetings is again important, because attending meeting is not for theory only. You get closer to senior people, you get closer to colleagues, you get more, you see what people are talking about, okay? And then you can introduce these things. So SI, again, we are introducing, because the most labor part of cytogenetics, after you do harvesting manually, okay? And unfortunately, machines are available now, automated harvesters. So you can do harvesting automated. Then the time consuming is counting or screening for these metaphases, 20 at least, if not 100. So imagine if you have 20 cells to out of the hundreds to screen and photograph for the technician. That's if each of them will take 5 to 10 minutes, then that's another an hour or two, and you have 20 cases per day. So how many people you need to do that? So if you remember, and I'm sure this is something already 7-8 years in your laboratories, the CellaVision. You know the CellaVision. CellaVision, and instead of putting 6, we used to have 6 technicians counting manual differential. Now in CellaVision, it captures all of this. They did the same in cytogenetics. So the machine overnight, the platform, you put 80 or 90 slides, all what you have that day, and it will go over it overnight and capture those 20 cells for you, like the CellaVision. And when the technician comes in the morning, he can start analyzing. So you see how much time has been saved from, same thing can be done for fish, because fish you need 100 cells. You put the slides of fish, and overnight it will capture 100 cells with good quality, and in the morning the technician will do. It can do even the percentage for you, okay? Now, we have a gap in between. Now, we did the harvesting, we did the automated meta finding, we can attach it to the lab information system, But what about doing fish manually? You have seen fish, huh? How fish is done. Jars of alcohol, different percentages, and dark room, and all of this. Now, there are automated machines. One of them, maybe I have shown previously. Different machines which you can put the slides of fish, and you add the probes on it and leave it overnight. You can have 40 slides of fish overnight. Not doing it manually. It will do all the different alcohol jars and all this. And then you take this 40 to the SI. And the SI will screen the metaphases for you, or screen the inner phases for you if it is fish, and then you just come and analyze. So basically, one day harvesting, one day fish automation, one day SI, one day reading. So 4 or 5 days, you should be able to get the cytogenetics results, not 28 days. Again, it's all dreams, but with your efforts can be reality. Thank you very much.
Sure.